Today's topic is abortion. When pregnancy loss occur at more than 20 weeks or fetal weight is equals to 500 gram, we consider it as abortion. Two things to remember is that when the fetus is at 20 week, weight is 330 gram, and when the fetus is at 22 week, the weight is 500 gram. Means 22 weeks match the criteria. So 20V or fetus weight is 500 gram, both are different criteria. Okay, so we considered abortion as more than 20 week or fetal weight is equals to 500 gram. Recurrent abortion. Recurrent abortion is more than 3 abortion. According to ASRM, when two or more consecutive loss of recognized pregnancy by USG at more than 22 weeks, we called it as recurrent abortion. More than two consecutive loss and recognized pregnancy by USG at more than 20 weeks, we consider it as a recurrent abortion. Causes. Four causes. First is APLA syndrome, antiphospholipid antibody syndrome, uterine abnormality, that is congenital and acquired. Congenital is septate uterus and acquired is cervical incompetency, fibroid or polyp. Chromosomal abnormalities and hypothyroidism. Most common group causing recurrent pregnancy loss is endocrinal cause more than uterine cause. So endocrinal cause will lead to more recurrent abortion as compared to the uterine causes. Now investigation. As the four causes, we will do the four investigation. That is APLA syndrome, APLA antibody. Uterine abnormalities, we will go for USG, uterus, that is TVS, transvaginal sonography. Then for chromosome abnormalities, we go karyotyping, and hypothyroidism, we do TSH. Now syphilis and torque do not cause recurrent pregnancy loss. So that's why torque, HIV or VDRL tests are not done. Torque, HIV VDRL test is not done in recurrent pregnancy loss. Most common cause of T1 and T2 spontaneous or isolated abortion is aneuploidy. Then comes trisomy, then comes monosomy, and then comes trisomy 16. So aneuploidy is the main most common cause of T1 and T2 spontaneous and isolated abortion. Now, what will be the most common uterine cause in T1 is septate uterus, whereas in T2 is cervical incompetence. And most common risk factor is increased maternal age and previous history of abortion. Now, abortion and how will we approach it? So, we will divide it into product of conception coming out and product of conception not coming out. We will check internal loss per vaginally. If internal loss is open, then it is incomplete abortion. If internal loss is closed, it is complete abortion. So here it is open, it means more product will come out. It is closed, it means the complete abortion. Now if the product of conception is not coming out, internal loss and checking per vaginally, if it is open, it is inevitable abortion. If it is open, it is inevitable abortion. If it is closed, we will check per abdomen. If the height of the uterus is equals to period of gestation, then it can be threatened abortion. And if the height of the uterus is not equals to period of gestation, then it will be the case of missed abortion. So if the patient come on second or third day with the complaint of bleeding in case of missed abortion, the height of the uterus will be equals to POG. So how will you differentiate both? We will do USG. On USG, if the cardiac activity is present, then the case is of threatened abortion. If the cardiac activity is absent, then it will be the missed abortion. So let's do quick revision. Product of conception coming out per vaginally, we will check internal loss. It is open, it is incomplete. Open, incomplete, close, complete. C for close, C for complete. Now product of conception not coming out. If PV internal loss is open, it is inevitable. You can see both in the open it is incomplete and in open it is inevitable. So both in, if you go in you will open, and in close we will check per abdomen. Per abdomen, if the height of the uterus is equals to POG, threatened abortion and cardiac activity will be present on USG. If the height of the uterus is not equals to POG, cases of missed abortion and the cardiac activity will be absent. Now, how will you manage the case of abortion? So, abortion first is threatened abortion. And threatened abortion, as we see, internal os was closed and no product of conception was coming out, as well as the height of the uterus was equals to POG. So the case is of reversible because the internal os is closed, no product is coming out. So the case is of reversible and management is expectant. Now inevitable. In inevitable abortion, as we know, internal os was open, but the no product of conception was coming out. So it is not reversible case. Okay, it cannot be reversed. Management is emergency suction evacuation. In case of incomplete abortion, we will do emergency suction evacuation. Incomplete abortion, more product is about to come out, and in that case, internal os was open and the product of conception was coming out. So we will do emergency suction evacuation. In complete abortion, we'll do conservative management, that is serial beta HCG titer will check until the UPT is negative. Okay, either we will do conservative management and we will check serial beta HCG. Now, in the case of missed abortion, it is USD based diagnosis. Obviously, you can't find any symptoms or signs, so you will check for USG. If the mean sac diameter is more than or equals to 25 mm and crown drum length is not measured, I described this all in a separate video. You can check it. I will mention the link. MSD more than 25 mm and crown drum length is not measured, or CRL is more than or equals to 7 mm but fetal heart activity is absent, or the cardiac activity earlier noted is now absent, we will consider it as a missed abortion. MTP, medical termination of pregnancy. It can be done till 24 week. If the patient come with contraception failure, you can do it till 20 weeks. In severe congenital anomalies, there is no upper limit. Medical boards. It includes three parts, that is gynecology, radiologist, and pediatrician. The question is being asked. One doctor is needed when the abortion is till 20 week, and two doctors when the abortion is of 20 to 24 week. Now, what will be the qualification of doctor? Till 12 weeks, any registered medical practitioner assisted 25 MTPs, and 12 to 20 weeks RMP with 6 months of house job in OBGY, or a registered medical practitioner with 1 year of experience in any hospital with all facilities, or diploma and DNB in OBGY. All records should be stored till 5 years. All the MTP records will be stored till 5 years. Now, what are the methods? How will you do MTP? If less than 9 weeks of period of gestation, you will do medical abortion. 9 to 12 week, you will go for suction and evacuation. And more than 12 weeks, it will be mesoprost. Okay, so if less than 9 week, you will go for medical abortion. 9 to 12 week suction evacuation, and more than 12 week mesoprost. Now T1, trimester 1 and trimester 2, how will you do? The mnemonic is MSM. MSM. So the M is for medical, medical is stands for M, S for suction and evacuation, and manual vacuum aspiration is M. MSM. Okay, so T1, we will go for medical, suction evacuation, manual vacuum aspiration. Now in T2, MSDH. M stands for medical again. So here the best drug is mesoprost. You will give mesoprost to the patient. You can also give extra amniotic ethacridine, an intra-amniotic saline, or oxytocin. So you will give four things: mesoprost, EAE, intra-amniotic saline, and four is oxytocin. Now S stands for suction evacuation, D for dilatation and evacuation, and H for hysterectomy. Okay, so MSDH. Here in first trimester, you can also use menstrual regulation syringing, but it is outdated, not used nowadays. Now, suction evacuation. Suction evacuation will be done with the help of Karman's cannula and suction machine. Karman's cannula and suction machine. Now, the number of Karman's cannula, the question is asked. What will be the number of Karman's cannula? It will be equal to the size of uterus. Whatever the size of the uterus, you will choose the same number of Karman's cannula. The pressure generated is 600 mmHg. 600 mmHg pressure will be generated. And in the area where no electricity is available, you will go for manual vacuum aspiration. Okay, now manual vacuum aspiration. MVA syringe have two pinch valve. Okay, here two pinch valve is important because mostly in Viva you will be asked that how will you differentiate between MVA syringe and menstrual syringe. So MVA syringe will be having two pinch valve, whereas menstrual syringe will be having one pinch valve. Now capacity of MVA is 60 ml and the pressure is 660 pressure, as in the Carmen's cannula it was 600 pressure, but in the MVA it is 660 pressure. Now menstrual regulation syringe, it is only having one pinch valve. 50 ml is the size and it is not done nowadays, it is outdated. So medical abortion will be done till 9 week. Day 1 mifepristone 200 milligram single dose. On day 3 you will give misoprostol 800 microgram, it is microgram, orally, sublingually or pervaginally. And in 24 hours, you will check it in 24 hours, abortion will occur. It will as bleeding. If the patient bleed, it means that misoprostol have worked. Now uterine perforation. So uterine perforation will occur in the two cases, that is Hagar's dilator. Hagar's dilator will dilate the cervix. So if the perforation is because of Hagar's, we will stop the procedure and monitor the vitals. Carmen's cannula, while procedure, if the Carmen's cannula perforate the uterus, you will stop the procedure. Do not remove the Carmen's cannula. Put it as where it is, and immediate laparotomy should be done.